Our next presenter, just so y'all know, this is the guy that was texting me this morning while we were having technical difficulties, telling me to sing, and sent me some very bad jokes, which I did not read to you. His name is Dr. Timothy Bilbruck, and he's the Medical Director of Addiction and Co-occurring Disorder Services for Alliance Healthcare Services. And one thing I know about Dr. Bilbruck is he's very passionate about his work, and he has helped a lot of people here in Shelby County. And he's going to be talking about challenges to opioid treatment in Shelby County. Are you there, Dr. Bilbruck? There he is.
Hello.
Hello.
Good morning, everybody. Thank you, Josh. I appreciate you hosting, and I want to thank Jack and the Memphis Prevention Coalition for putting on this event. Oh man, that video is still powerful. You know, I remember Stephanie when she came in a detox, and now she's out there with Ron and A Better Way on Friday nights giving back, and she's been to the street team for overdose prevention events as well. So and Leroy, man, he's an inspiration too. He's really gonna come a long way. Okay, so so I really do have a tremendous amount of respect for what I call the people on the front lines, what they do, like Ron and his team. I mean, the biggest thing I think they do, they harm reduction, absolutely. They do all that, but he's out there showing that somebody cares, you know, that somebody still cares for these people. And you can see he's real passionate about what he does too. So I've learned a lot this morning. Mr. Jackson had a lot of information, and Ron did as well. But I'm not going to have a PowerPoint. We're going to have a conversation. Although I did hire an artist to you know, so I'll be showing you a few pictures along the way. Josh mentioned my role at Alliance, where I treat both psychiatric disorders, both the primary psychiatric disorders and substance use disorders. We have detox services with Alliance. We have mobile crisis that serves the entire county, where our crisis assessors go out and meet people where they're at. We work closely with SOAR Pathfinders, Jack and his team, Ron and his team. If there's ever somebody in need, or whenever they get ready and they want to come to detox, we try to get them in. We have enhanced outpatient services along with medication assisted treatments or medication treatments for opiate use disorder. Those are usually in conjunction with intensive outpatient services. We also collaborate and coordinate with a lot of the residential treatment centers here. And let's see. Oh, we have at Alliance, we have therapists, treat trauma, we have case management. We just have a lot of services to offer people who are struggling with co-occurring disorders. Okay. So the first topic I wanted to review is stigma. Now, when Jack asked me to do that, I'm a procrastinator, okay, by the way. I got up at 4:30 this morning and put together some little cards. But so I just was thinking, whenever he sent me the email, what I want to talk about, I just sent him 5 things that were on the top of my mind that particular day. But stigma is huge. And I see it not only in the community, but I see it in mental health organizations. I see it on both sides. See, the old paradigm is that, mental health, like community mental health centers, we treat mental health, right, or behavioral health. And substance abuse treatment centers treat substance abuse. Well, there's some people in traditional community mental health centers or mental health centers that say we don't treat substance use disorders, that that I don't feel comfortable doing that, or they may even think it's a choice, that it's not really a psychiatric disorder or a true disease. And there are people on the substance abuse side that don't like dealing with people with psychiatric disorders or won't allow certain medications that the patient may need into the facility. So the future, kind of like we transition from, residential to more intensive outpatient services, we're going to see more integration of services where we're working together and treating co-occurring disorders, or at least that's my hope. And that's where I focus most of my time and efforts. So both, like I mentioned, both are psychiatric disorders. That means both are diseases that affect our brains, the brain. And, I mentioned choice versus disease. I think there's enough shame, regret, remorse, and shame in these individuals that, that they really don't need, our judgment, our criticism. They really need our support and our understanding. So there's a conversational type of education that I like to use. Whenever I meet somebody that's resistant, that may be in the mental health field, or maybe a family friend or something like that. And I'll discuss this with our patients too, to try to diffuse that shame. Nobody has come into my office and said, Dr. B, whenever I was in kindergarten, I stood up and said, when I grow up, I want to have bipolar disorder, I want to have substance use disorder. Nobody has ever come into my office and said, hey, life's going great, work's great, family's great. I've been working on my golf game. I just want to stop using, heroin and fentanyl. These drugs are so powerful and they're so devastating to their lives that there must be something more serious than just choice here. And then there's because if they could stop, they would. So tell them to stop. Why can't you just stop? I mean, they've heard that. If they could stop, they would stop. The evidence-based approach. So this is whenever we get into some of the evidence. Now, I'm not going to talk about a lot of it, but we know that there's approximately a 50% genetic or inheritability to substance use disorders. So some people are just born with it. 50% risk. They didn't get to choose. Then, as has been mentioned, there's a lot of social factors that from the environment that go into that. Me personally, I see a lot of trauma in patients with both mental health and substance use disorders. Matter of fact, using drugs is a good way to avoid dealing with trauma. And not only that, during the drug use, they usually experience more trauma. It's very traumatic being out there using drugs. It takes them to places that they never expected to go, and gets them in high-risk situations that can be very, very dangerous, like almost dying, or being, sexually assaulted or physically assaulted and things like this. So we, unfortunately, right, we don't get to pick our country that we're born into. We don't get to pick our state. I'm from Alabama, Roll Tide, but I didn't get to pick that. I'm glad, now, because they have the greatest football team in the world, but I didn't get to choose that. I didn't get to choose the city I was born into. I didn't get to choose my parents. I didn't get to choose what gender I am. I didn't get to choose which race I am. I didn't get to choose the religion I was exposed to. I was just born into that, okay? And I think most people play the cards they're dealt in life to the best of their ability and wind up in places doing things that they didn't intend to do, right? So one study I do want to mention is a study that was done 6 or 7 years ago, I think, by the UT Child and Adolescent Psych Department, and it was the ACE scores, the Adverse Childhood Events, and it was a fairly large study in Shelby County. And if you have 4 adverse childhood events in your life, this is going to be divorce, parents with substance use disorders, mental health disorders, some kind of physical or sexual trauma. All these things, count as a hit or a adverse childhood event. So if you got 4 hits or more, then it sets you up. Research shows it sets you up for bad juju in life, like increased risk of mental health disorders, increased risk of substance use disorders. So if you happen to be born with a 50% genetic risk, plus you have 4 hits or more, I mean, it's like the odds are stacked against you. You know what I'm saying? So that's my spiel on stigma. We could take a lot of time. There's also language that we use, that's stigmatizing. We need to public awareness, prevention. We've heard a lot about that, but we really need to understand this, make sure we're not propagating that stigma. And so, because saying addicts, like, instead of persons that suffer from the disease of addiction, or ASM likes to call substance use disorders, or people that use IV drugs, things like that. There's less shaming terms, because those have negative connotations, right? And they own that stuff. They come in and say, well, I'm just a junkie, I'm just an addict, I'm just a garbage can junkie. That's somebody that uses everything, is what they'll tell me. And that's how they feel about themselves. And then they'll, we call, like, if you're in drug screenings, they call them clean and dirty or hot. And I'm like, it's not clean or dirty. It's either positive or negative. You either have this substance in your system or you don't. It doesn't mean you're dirty or your urine's dirty. We shouldn't. Well, anyway, I don't think we should be using terms like that. And certainly ASAM doesn't either. That's the American Society for Addiction Medicine. So let's talk about the addicted brain. And I think Mr. Jackson mentioned this in his talk about the development. So it is viewed as a developmental disorder, right? Because, the brain, most substance use starts in adolescence, maybe even prior to adolescence in a lot of people. And this is a time when the brain is developing. It develops real rapidly early on. And, you see great changes. Babies, if you watch them over the first few years, they learn all kind of new stuff, speech and walking and all this stuff. And then throughout their lives, up until roughly age 18 or so, the brain kind of stops growing and it starts what we call remodeling or pruning, okay? So it's kind of like you're refining pathways that work and maybe getting rid of pathways that don't, like you're pruning a bush. We think this is one of the reasons why first psychotic episodes in schizophrenia also occur during this period. Late adolescent, early 20s may, occur in a college age student, but there's still stuff going on there. And using these substances can alter that neural development. And so, you're born with the genetic risk, you've got this trauma, you're using early, you've got neurodevelopmental issues. It's multifactorial, if you will. The disease, like many diseases, have, multiple factors that contribute to it. Okay. Conceptual framework. So there's this use, withdrawal, and cravings that you may see that I refer to is called, they call it like salience, and then they'll call withdrawal, negative affect withdrawal, and then they'll like preoccupation. It's basically, the concept is you have intoxication, you feel bad afterwards, you have a preoccupation with using again. So somebody said, I think it was somebody Bradford sponsored, which made a lot of sense to me. It's like you have pain, you use drug, you get relief, right? The relief's temporary, usually causes more pain, or negative affect withdrawal. So you use more drug to get relief, and usually short-term relief causes more pain, use more drug. So there's this vicious cycle that you get locked into as well. And a lot of it has to do with our limbic system. So I've got my brain here, okay, my model of the brain. This brain sits up in my head, kind of like this, and the brain stem comes up and it sloshes around in some fluid. Okay. If we open it up, open it in half. So if you cut my brain in half, you would see down in here, there's coming up off the brain stem, there's these, what we call the limbic system. Our limbic system is very primitive structures. And if we break it in half again, you'll see those are dopamine neurons and their projections. So there's dopamine neurons that project all through our brains from the, and I'm not going to talk about the ventral tegmental area and nucleus accumbens and all that stuff, but they project through different pathways, some to the cortex, others mesolimbic, some for movement. Anyway, the point is, this limbic system is a very primitive structure, okay? So it's a structure that we share with almost all mammals, well, all mammals, almost all living creatures, if you will, until you really get down to insects and stuff like that, then maybe not so much. But even lizards, some people have referred to it as the lizard brain, would have something similar to this. And it's basically, its role is survival, right? So it's where you have the fight, flight, freeze responses in trauma that are automatic. You don't think about these. Bear chasing you, heart starts racing, pupils dilate, the blood shifts from your digestive tract to your muscles. You have increased heightened awareness of your senses. All that happens. You don't even have to think about that. That just happens. So it can take over. It can override all this gray matter. See, what we have evolved is all this gray matter, this cortex that we call it. And this frontal cortex is where we're supposed to have our insight, judgment, decision-making, what they call executive functions. Okay. So we have basic instincts and drives that also are, necessary for survival, like food. Like food should be pleasurable, because if it feels disgusting, we wouldn't eat, we would die, right? Sex for most people, unless there's trauma, can be pleasurable, and it's usually to procreate the species, because if we didn't, our species would die off. Bonding with infants' family is usually pleasurable, unless in-laws, maybe not. But because it promotes the hunter-gatherer, the kind of clan, the tribe, instincts that, we're safer together. So all of these things are pro-survival. And the common pathway for almost all substances of abuse, no matter how you get there, it comes down to a dopamine. Dopamine motivated behavior reward system. So this limbic system, okay, is getting hits of dopamine, basically, and dopamine is associated with pleasure. So we're hardwired to pursue pleasure, if you will. But even a bigger driver is to avoid pain. And that comes into play in withdrawal, because we have pain for a reason. It signals danger, right? This is bad. This is something we need to avoid. So we have this pursuit of pleasure and this avoidance of pain. And I think my artist came up with a couple of illustrations for us here. This would be my 11-year-old son, Bentley. And so here is our gentleman down there. He's pursuing pleasure. Okay. He's kind of, you see the little bitty guy down here. And this is his concept of pleasure. I just said, can you draw a guy, chasing pleasure? And that's what he came up with. Pretty cool. And I really like the pursuit of pain. I mean, the avoidance of pain. And then he's got the little guy running away from pain, right? But the earth's crumbling. He's got fire, lightning, that big ball, wrecking ball. So whenever we're using drugs, especially opiates and meth and some others, we're getting hits of dopamine way up here. Normal pleasure, food, sex, bonding, you get hits of pleasure down here. But with opiates, you get huge hits of dopamine, right? And so your baseline level of pleasure shifts. It actually shifts. And after you use, it can take up to a year, some say 2, before you can really experience normal pleasure to the same levels that you did pre-use, which for some people is like 12 years old, right? So it's so powerful. This is so powerful, the huge hits of dopamine that you get, that the limbic system feels. Limbic system doesn't think. The limbic system feels that it needs that to survive. It needs that more than food, more than sex, more than family. Okay, and you'll see that. You'll see this in especially in the later stages of addiction. You'll see them. They're not eating. They're not having sex unless they're doing it to get drugs. They're not. They've broken off ties with family, children. So it's just that powerful. It hijacks this primitive structure of your brain and it overwhelms the cortex, just like fight, flight, freeze, if you will. It's survival. That's what it feels like it needs to survive. Okay, now we got to talk about, so what we're going to do. We got to talk about detox treatment. So Ron finds somebody out there on Friday night that's interested in detox. They've decided it's time. They want to get some help. So he calls me up. We try to get him into our detox unit. There's a couple of different, they call one medically monitored detox versus medically supervised. You may hear them as like medically supervised as kind of a lower level, which is social detox, and medically monitored as a higher level. ASM grades them. And we have the highest level, which is a 3.7. So it's the medically monitored detox. And we provide 24-hour nursing care, daily visits from either myself or a nurse practitioner that works with me. We provide medications like clonidine, buprenorphine. So we initiate buprenorphine there. And then all other supportive medications that they need for nausea, cramping, diarrhea, aches, muscle relaxers if they need it, whatever they need. Plus, if they have co-occurring disorders, then we can treat those or get them started on medications. And I'm going to talk about that later, how important that is. But I do want to say that detox is not treatment. Medically monitored withdrawal management is just that. It is to get them through that withdrawal period, that pain avoidance period. Okay. Like Ron mentioned, it's huge. I mean, it's like the fear of going through that is sometimes worse than the actual withdrawal, especially if we get them in and they see that, you know, we can manage it pretty well. Then we have, you know, transitions. Okay, so we do that. Transitions are crucial. I can't overemphasize. And you saw Danielle on the video clip. Jennifer Hill, she's the detox program coordinator. Danielle, she's like discharge planner, but she's does more than that. She does some therapy too. And she's really good at connecting with our affiliates in the community, residential treatment centers, our intensive outpatient programs. We work with a couple of grant programs, the SOAR grant program, State Opiate Response, and the SMART program, which is a SAMHSA federally funded program. So we can get our uninsured into IOP on, you know, medically assisted treatment with buprenorphine products if they need that. If they need residential treatment, then we can get them into those resources as well, like at CAP, Serenity, Harbor House. We work with them. And one of the new developments, this was crucial, is we didn't have that residential step before transition to IOP MAT. Like 6-8 months ago, we had the IOP MAT for uninsured, but we needed that residential piece because some people lack resources. They don't have a place to live. They come off the street, you know, they burn all their bridges or whatever. So they need a safe place. We can't set them up to fail. We can't come in, we can't bring them in, detox them, and send them back out into the same environment. There's so many other factors that have to be addressed to treat their substance use disorders. So we have to set them up for success. And so bringing Matt into the residential treatment programs has been huge. And we'll talk. You can also use Vivitrol too, because that's a good time. They can do the first 10 days, and then they can get on Vivitrol, which is another option. I'm sorry, not Vivitrol. Naltrexone extended release. I'll try to avoid trade names too. Okay. So now a couple of important things I want to mention is, one, we only have 4 funded uninsured beds for detox. 4. We can take 9. We only have 4 that are funded for uninsured. So this is a big deal, right? Because the demand is usually a lot higher than, we try to be creative about this, but it's usually a lot higher. Matter of fact, the first 3 months of the the COVID pandemic, when everything shut down, like March, April, May, when we were having like more drug overdoses, almost double than we're having COVID deaths here in Shelby County. We had our waiting list, I think in May or June, had gotten up to like 70, okay, 70 people on our waiting list. And because I think Pathways has shut, anyway, there was a lot of people that, you know, weren't, anyway, that was just what was going on. And there's this 48-hour window, like Ron and most of these people out there on the front lines know, from the time somebody reaches out, seeks services, until we actually engage them and get them in the services, we have maybe a 48-hour window. And once that closes, that, because withdrawals set in and they go back to using, and we may not see them again for a long time. So trying to get them in, if I can't get them into detox, we try to get them into the clinic and get them started on medication-assisted treatment with buprenorphine, because I can start it in the clinic, especially if they have they can go stay with family or something, if they have a safe place to live and access to transportation. Fortunately, right now, most of the intensive outpatient groups are on Zoom, so they can participate in those as well. I got to hurry up. Let me see. Sober living. Sober living is huge. We need sober living. Fortunately, there's sober living. They're starting to open up too. They're starting to, accept the medication-assisted treatment is valid and helpful, and they're starting to allow people to come there on MAT, which is great. Okay, so I put MAT as part of harm reduction. I'm not sure if it is. I mean, it is in some sense, but the studies show that medication alone may be just as effective. I don't really agree with that, because I see people that I treat with buprenorphine, naloxone, and they may resort to using something. So they may have been a big drinker in the past, gotten a lot of trouble there, and then once they found the pills and progressed to, heroin and fentanyl, they no longer drink, but then they get, they get off the heroin and fentanyl and they go back to drinking heavy. And so there's still this, this behavior from all this drug use and, this frontal lobe deficiency, and things still need to be linked back up. And so I only do the medication assisted treatment or medication treatment in conjunction with enhanced or intensive outpatient services. That's my philosophy, and I think, I have reasons for it, but there's so in our community, there's a lot of 12 steps. So outside of the intensive outpatient and residential treatment centers, and some of them focus more on a 12-step model, there's some resistance from, traditional abstinence-based programs. And they may tell my patients that they're not really in recovery, because they're on, Suboxone or buprenorphine. And so that they shame them, and they're afraid to tell like their sponsors or other people. And sometimes the 12-step sponsors have encouraged them to get off their medications. I've even had them encourage them to get off like antidepressants before, and they've had a recurrent major depressive episode because of that. So, that's one of the things we need to address in our recovery communities, and because it's important for them to be engaged, and they need that support of a recovery community outside of intensive outpatient and stuff like that. But or I think it's important, but we need them to be more open to these newer treatments. There is a group I want to mention. It's the MARA group. It stands for Medication Assisted Recovery Anonymous. That is 12-step based. It meets at St. John's on Peabody, 5:30 to 6:30 on Wednesday nights. And it is for people who are in recovery but are on medications to treat their substance use disorders. And that's where they can talk openly about these issues, which I think is good. Now, I wanted to talk a little bit about the different medications, but I think somebody else is going to do that tomorrow. But I got to show you this. So I asked my son, I said, I kind of explained a little bit about the receptors and the opiates like fentanyl, how they bind to the receptors in our brain. And then we have medications that go in and they treat that, and they kind of put up like this force field or something around there so those other medications can't bind. And so I guess he went with the force field concept. And so he's got this is the mothership, I guess, but we can run with this. So these are the landing pads, but they're actually receptors. So if we call these opiate receptors, these little guys, and they're really not little, let's call them buprenorphine, okay, for instance, which is a partial agonist, antagonist, and we're gonna partial agonist, but I'll explain what that is in just a second. But their tractor beams are a little bit bigger than Mothership. So Mothership has a tractor beam. So Mothership is fentanyl. Fentanyl is very powerful, okay? But it has a weaker tractor beam. So buprenorphine can go in there with their enhanced tractor beams or binding affinity. It can go in and bump big fentanyl off. And whenever it does, you get a trickle of dopamine, right? You don't get huge surges. So it doesn't shut the faucet off. And I use this analogy with my patients. So it doesn't shut the faucet off, but it won't allow it to be turned all the way on. Okay. And it sits there stuck on that receptor tightly. Like if I'm buprenorphine and I'm sitting in this chair, then, you know, if another opioid comes along, tries to pull me off the chair, they're going to have a hard time. But if enough opioids come along, enough fentanyl comes along, they'll be able to get me out of this chair just by kinetics. And so they help reduce cravings because something's sitting on that receptor, okay? So it's not hungry, if you will. It's not like if you detox them off and just send them back out, they're at increased risk of overdose and death because the opiate receptors upregulate to try to grab any opiates left in the body. They are in the brain. And but you can overdose. I had one patient early on, this may be a year and a half ago or something, whenever we started doing buprenorphine as part of our detox protocols, that wanted to, you know, get on the naltrexone, the long-acting naltrexone, and was very committed, went through just the clonidine protocol and was going to go to a treatment center in Colorado or somewhere, and left with his friend associate, his female friend. She came back 3 days later and told us that he had overdosed in a hotel room with a needle in his arm. So and I tell him, if you still want to get high, this is not the medication for you, okay? Because it will blunt the effects, okay? So either you won't get high, or if you try to get high, you could die, okay? So you're either going to waste your time and money, or you're basically going to be trying to kill yourself. Suboxone to a lesser degree, but can still happen. I had a patient on Suboxone, 16 milligrams a day, took it regularly, resorted to using one day and was in the car, and he said he snorted some stuff, and he said as soon as he did it, it hit him, and he knew, you know, he was going out. And he did. He overdosed, had to be Narcan taken by his girlfriend. Fortunately, was in the car, taken to the emergency room. And because Josh had given us those Narcan kits to give out, he survived. So I know you can overwhelm that blockade with patients on Suboxone too. So again, I always caution them about that. And I worry if I have them on, buprenorphine. I'm sorry, I keep saying Suboxone, but if I have them on buprenorphine and they keep using fentanyl, there's a point where I just say, it's just too risky. I'm concerned, and they would need, a higher level of care. So the overall goal. So regardless of how you feel about MAT, how you feel about these medications, if our overall goal in recovery is what you saw with Stephanie, okay, where you improve functioning, where in social, occupational, housing, legal, they're restoring relationships, there's healing, there's well-being of the entire person, okay, then that's what recovery is, okay? It's not a disorder unless it disorders your life, right? So it can restore family, all right? And there's a family, there's little kids in the park. walking a dog. I'm not sure if that's family because we have 3 dogs. Here's work, so occupation, and he wants to be an architect. So those are little guy, they're building a building and they got their little helmets on or hard hats on. And then community, I thought this one was interesting. So I thought that was me playing golf with my golf bag and club, but he said no, I was picking up trash. So we also, they sometimes there's legal issues, and like we saw with Leroy, okay, and we encourage them to resolve those, take responsibility for those and resolve those. We don't want this to happen again. We don't want this to happen to Leroy or anybody else again. We don't want people that are suffering from substance use disorders to be incarcerated. We want to get them into treatment, right? Unfortunately, the symptoms of substance use disorders are behaviors that cause problems in society, if you will. Those are the symptoms of this disorder. And that's why there's a lot of stigma around it. And we want them to be able to pursue their dreams. Okay. I think at the end of the day, we really want them to pursue their dreams. And he has some interesting dreams on here. Art, baseball player, he likes baseball, astronaut, superpowers. Got to have the pot of gold at the end of the rainbow, right? And he wants to ride a dragon, which, you know, that may be something that.
Dr. Bilbruck, you ready to take some questions?
You know, I am. Well, I could go on because I really haven't gotten into co-occurring disorders. But let me say, just real quick, that substances can cause mood disorders and psychotic disorders. Sometimes they're using substances to treat depression, anxiety. There's a 4 times greater risk of substance use disorder with bipolar disorder. Primary psychotic disorders can be challenging. We won't go into that. So is it the chicken or the egg? It really doesn't matter to me. The take home is they both must be treated early to achieve stability, and they need long-term follow-up. Both of these are chronic disease of the brain. And I appreciate your time, and I'm willing to take some questions.
Thank you. All right, attendees, if you would, please use the Q&A function for the questions. I'm sure you've noticed we have closed captioning going on in the chat box, so we kind of lose the questions very quickly. So use the question and answer button in order to ask the questions. Also, I'm going to put the link to the evaluation in the chat box. So look for that. I'm about to do it right now. When you click on this, you will go to the evaluation, fill out the evaluation, and then you can click on either your continuing education credit or a general certificate. So first question from Elda Bear, are you able to help pregnant mothers with their drug dependency?
Absolutely. Yes, with the opiate use disorders, yes, they come into our detox unit, pregnant mothers. Now, if they're late, really late trimester, we may, like if they're getting close to delivery, we may refer them to the high-risk OB at Region 1 Health. But we usually get them, what we'll do is we'll get a medical clearance. So they just found out that they're pregnant. They come in, they didn't know. They come into they get an assessment in our crisis unit, our walk-in center, we'll send them over to get a medical checkout or send them out to OB to get a medical checkout. Once, pregnancy, we know mom and baby's okay. Then we will do so there's 2 treatments for opiate use disorder in pregnancy. That's methadone and buprenorphine, the buprenorphine monotherapy product. So that's what we initiate in detox. So it's really not detox, it's more like induction and stabilization. And we do that very carefully because we don't want to precipitate withdrawal. I really didn't get into that, but we have to do that very carefully with very low doses. But we have a specific protocol for pregnant mothers with opiate use disorders. Yes.
Thank you. All right, and from you have 2 questions from Bama Fan 81. The first one, will Saban ever beat Dalvo? And the
Saban, it's Saban, Josh. Come on.
The serious question is, in your opinion, how many detox beds should Memphis have?
For uninsured, I think we could easily run 10 and sometimes 20, but I would say 10. If we really wanted to do the 48-hour, if we really wanted to have that kind of responsiveness, where we get the call from Ron, we've got a bed. You know what I'm saying? If we really want to do that, we probably want, I want to say, 15, maybe even 20. I mean, if we really want to do that, if we want to have that level of care, I would rather have a few spare beds than not have enough. I don't like turning people away. I don't like having limited resources where I have to try to prioritize this over this. Like we do prioritize pregnant IV drug users over, pregnant drug users, and then IV drug users. So we do have some, but it's just, I don't like it. It keeps me up at night sometimes.
Certainly not enough. Agreed.
Not enough.
All right. Stacey Abram wants to know, how do you encourage someone who feels stigmatized by the use of MAT?
I tell them this is a medication. I'm a doctor. This is a medication. It's approved to treat this disorder. First of all, I got to get them to understand it's not a moral issue, that it's a medical issue, that it's a disease of the brain, okay? And it's a chronic disease. And if I can get them to understand that, and this is a medication that we're using to treat it, if sometimes, I can even say, well, it's a tool, okay? It's a tool we're going to use to get you stable, get you engaged in recovery. If at some point, because I've gotten this too, well, I don't want to be addicted to this and trade one for the other. I mean, because they hear that. I said, let's not talk about that today. Let's wait 6 months. Let's get you stable. Let's get some things on track for you. And then we're going to have that conversation. I've had a few people switch to naltrexone. Naltrexone, long-acting naltrexone, and actually do that. So it's possible to do that. But yeah, that moral, failure kind of thing is what drives that.